In the first presentation from Yvonne, you heard there were 5 Marfan clinics in the Netherlands. One of them is the clinic at the Radboud UMC in Nijmegen. And the Radboud UMC in Nijmegen is very far in developing multidisciplinary care for Marfan patients. And more to tell us about that is Daphne Doze from the Radboud UMC. Welcome.
Good morning. Thank you for inviting me here. I'm Daphne Doze. I'm a nurse practitioner for congenital heart disease, and I also am involved in the Marfan care. And I'm here to tell you something about the way we organize the multidisciplinary care at our center. Well, other way. The content of what I'll be talking about is the Marfan care in the Nijmegen Radboud University Center. I'll tell you something about the instrument which we use to evaluate the health status in Marfan patients. I'll tell you something the way in which we use it in congenital cardiology. I'll give some of the results for Marfan patients and elaborate on the benefits and experiences. And the Radboud University Medical Center is an expert center for Marfan and related aortic disease. We have about 400 patients in care with Marfan. We have a weekly outpatient clinic, a monthly new patient clinic where there's screening. 2 times a month there's an outpatient clinic especially for children. Once a month there's a multidisciplinary meeting with more disciplines to discuss patients. And every week there's a cardiovascular radiology meeting. And furthermore we have a transition outpatient clinic. The multidisciplinary Marfan team is built up of dedicated specialists, and they have different combinations for different multidisciplinary outpatient clinics. For instance, the ophthalmologist, cardiologist, and the clinical geneticist, they have a multidisciplinary outpatient clinic for the new patients, and they assess whether a patient has Marfan syndrome or not. For instance, the pediatric cardiologist, the nurse practitioner, and the clinical geneticist have the multidisciplinary transition outpatient clinic for younger adults. For instance, the cardiologist, the obstetricist, and the clinical geneticist, they will be involved when there's a wish for children or pregnancy. In our center, we find it important to view or to approach the patient as from an integral point of view. And therefore we think it's necessary that we need to evaluate the total health status so we can improve self-management. From the new idea of health, or from the World Health Organization, it states that health status and self-management are key factors in long-term outcome for a lot of care is self-care and not only medical care. In the guidelines for congenital heart disease, it also states that the best care, or it's recommended that integral and multidisciplinary approach is used. From our hospital, it's sufficient that the patient should be more involved in its own care and have more right to decide in its own care, in his or her own care. And its vision is that the patient should be partner, and therefore it's necessary that we get more insight in what's important for a patient, and also that the patient has more insight in medical possibilities. So there needs to be a better interaction than it has been so far. And our hospital was involved in a voucher project where there were 7 patient organizations in which the Marfan patient organization was also involved on, well, the translation is not really good, but how well are you really? And it was a project where the NCSI, the instrument I'll be talking about, was used, and due to that project it was possible to make that instrument tailor-suited for Marfan patients. The instrument we used to give an idea of the integral health status is the NCSI. It stands for Nijmegen Clinical Screening Instrument, and it provides a summary of 4 domains and 16 subdomains. It's evidence-based, and you can use it in clinical practice, and it's quite easy to use. Furthermore, there was experience in our center in the care for COPD and heart revalidation. I'm not sure if that's a correct English word, but or rehabilitation. And so we use that instrument, and it targets 4 domains: physiological disorder, complaints, limitations in daily life, and problems in the quality of life. And these, in a normal care, medical care, there's a lot of attention to the physiological disorder, but it's hardly related, or the other areas of the health status are actually hardly related to the physiological disorder. So somebody can have a large problem medically, but still have hardly any complaints or have a good quality of life. It's not just a questionnaire that is used. It's also to assess the health status. It's also a method, and it gives an idea of the integral health status, but it can also be used to identify problems, and the instrument is used to define and identify an individual care plan, and it helps motivate the patient to change behavior and to make choices, own choices in the medical care. And it can be executed by a nurse practitioner or a nurse. Furthermore, you can compare it. So if and it can be used as a monitor, because you can compare the results from one year to the next year to the next year. This is an example of how what it looks like and how it's presented to the patient. Now, it doesn't really work. The above, this is the version which we first used before it was tailor-made for the Marfan patients, and the above, I think it's better to just, this part is related to the physiological disorder, but we found that in Marfan patients it didn't bear that much relevance, so it was altered for the Marfan suited. This is targeted for complaints, and it looks at fatigue, pain, shortness of breath, and emotions related to that. This is limitations experienced, and then it's limitation at home while walking or experienced by the patient. And this is about quality of life. This last part is about acceptation or coping, and we find that very important because everybody has a different way in how they deal with problems or with health issues. Because of its graphical presentation, it creates awareness. It does not represent the healthcare's opinion, but it's a reflection of what the patient has filled in it herself. And because of the conversation, there's a constant check to see what the problem is or where there's focus in a patient, and it helps to formulate relevant treatment goals for the patient, and that creates motivation because of the awareness, the commitment, and the breaking of psychological defense. So maybe that's a bit complicated, but this I think will help to explain it a little bit better. These areas reflect the different health status domains, and this quality of life, physiological functioning, complaints, and functional limitations. And you can imagine that, say, you have problems with your joints of the knee, and that is a physiological problem, but it also gives you limitations because you have problems running. And if it is your for your quality of life that you want to run a marathon, then you have a problem, because if you do keep on training, you get complaints, and everything is all disbalanced. And the balance is very important. So it's important that you want things which you can also, or you get satisfaction out of things which are also possible for you to do, or maybe things need to be changed in the physiological functioning. So maybe your knee needs to be repaired, or I think that explains a little bit more that it's very important. This also gives a lot of treatment options, because you can approach from different points of view. Yeah? You can repair the knee, or you can give painkillers for the complaints, or you can go to the physiotherapist and address the possibilities of the knee, or you can look at the wanting to run the marathon and alter that. So there are lots of ways, and then that gives a patient a lot more choices in what he or she wants and what is more suited. This is from the early graph from the early development of the instrument, and it's from the COPD, which is about obstructive pulmonary disease. But the idea from this graph is that there are two people with exactly the same physiological disorder. In this case, that's the airflow which they can blow. But you see that they have a completely different, they're completely different in the other health status areas. And that can, for instance, be that this person is a woman with young children, and having a lot of demands, having to run after the children and getting them from school and do shopping, while this might be a pensioned man who can fill in his own time and doesn't. So it's even though you have the same physiological disorder, it doesn't mean that you need to be treated in the same way. So here are some examples of the NCSI from Marfan patients, and this patient was very tired. He didn't find his pain serious, but it bothered him very much, and it occurred during activity. He was he was a bit short of breath, and it bothered him very much as well, and a little bit scared when he was out of breath. He experienced limitations at home and with walking, and also a lot of disturbance in the quality of life. When looking at the acceptance profile, there was some denial, some resistance, quite sadness, but most acceptance. With talking with this person, the problem was that the patient experienced problems because at his work during the break they would all walk, and all his colleagues would walk, and he couldn't keep up with them, and it frustrated him very much. And he tried, but then his knee started hurting, or his hip, I'm not sure which one it was. And he also got short of breath. But he also had a BMI of, BMI is body mass index, of nearly 35. And his problems had started when he had an operation, and after that gained a lot of weight. So he did not want to go to have his knee checked out by an orthopedic surgeon, but he chose to start with a physiotherapist, so his limitations would become better, and he wanted to lose some weight. So we sent him to a dietist. And that's an example. And this is another example of a patient very, very tired, and disturbance in the quality of life, and its person scores high on denial. Now you can imagine with denial that if you do not pay attention to your body too much, it can be a very effective way of coping. Just go on, or yeah, how do you say that? That's the Dutch.
How do you measure the denial?
It's a questionnaire. So a patient gets several questions, and they fill it in at home. And from different questions, and it's evidence-based, it deducts certain conclusions. And it's based on questions which the patient fills in. So denial is that you don't want to accept, or you don't want to, you're busy with what other people are doing and with the things, you go to your work, you do the things you expect from yourself or others expect from you, and then it can happen that at the end of the day you're very, very tired, and you sit on the couch and you think, what happened? And the neighbor, she does the same and it's fine, or my colleague did the whole day and that person goes running afterwards, or sporting, and I just don't know how they do it. But it's a way of coping, because when you're young, you can make a choice of ignoring that you're different and then doing what other people do, and that can bring you very far, but to a point. So you can imagine that denial brings with it the risk of crossing your boundaries, your physical or personal boundaries. And by seeing this person realized that actually had a lot of moments that was really, there was a young girl, that she was actually very tired, and so this is the next one taken. Then these are the new measurement, and that's the last measurement. And you see that the tiredness was better, the quality of life improved, but also she realized that she had limitations. So there were areas and it's a difficult process sometimes, but it did improve the quality of life. So from that we can refer patients to different areas. Well, I'd like to enlighten a few. We see a lot of results from the, I didn't know the right translation, work physician specialist, I'm not sure. It's a medical specialist who is specialized in work and income related issues. And we have now somebody who helps with the Marfan patients, with the congenital heart disease patients. And he's becoming expert in that area, and it's really helpful, because there's a lot of people that have issues with working or with wanting to participate. And another one, the digital modules are in development. So we think that might be a good way also to approach some problems which are more general to such as dealing with boundaries or saying no if you're tired or things like that. That could be difficult. And a special dentist. Sometimes Marfan patients have a lot of headaches, we noticed, and sometimes you see results from mouth physiotherapy. So that's something which we also more and more refer to. So it's very practical in usage. It's an easy to understand profile card, and it's web-based, so people fill it in at home before they come to the clinic. It takes a short time. Well, not quite. We have some more added, but it should be about 20-30 minutes to fill in. It's easy to interpret, and it can be executed by a nurse practitioner, and it supports a structural consult. This is something about the results. Back, we first did a pilot in 2013, and we started using it in 2015 and 2016, and then from 2016 onwards we start using the tailor-suited one for Marfan, which we don't have the results back yet. So this is from the earlier results. And in total, 540 patients filled it in, of which were 58 with Marfan. Well, this is how you can look at the graphs, where green is normal compared to healthy people, or the yellow part is decreased or increased, and could be interpreted as a risk of becoming a problem, and red or 3 is a problem. Well, this is something about like 11% was Marfan patients of the total group, and there are slightly more men than female filled in. Well, this is about the same, sorry. These are the results from congenital heart disease patients versus Marfan patients. And the second one of the two bars is the Marfan patient. And this is about quality of life. And you see that in 60% there is a problem with the quality of life, which I thought was quite large amount. This is heart-related quality of life. This is relationship. This is experienced limitations or impairments, and this is actual limitations. And this is fatigue, tiredness, and you see that that's also very high. And this is compared to people with congenital heart disease, but compared to normal people, that's just a green. So it's a large percentage, I think. Even though the number is still quite small, but I thought it was significant. This is man and female with Marfan compared to each other. Well, there wasn't a large difference in the group, but just to illustrate, you see that females experience slightly more problems than males do. We also looked at the age groups. We thought maybe with age the problems would increase, but actually you see at the younger groups before 25 or before 40, they have experienced a lot of problems. This one is about the quality, quality of life, and it's compared to the congenital heart disease group. So still a surprise, because I didn't know the problems experienced were that high. This is about heart-related quality of life, same idea, and you see the same trend actually relationship, which was also surprisingly that Marfan patients under 25 years age experience, well, more than 50%, 55% experience problems with relationships. And so that was a surprise as well. And fatigue, well, that's huge for young people. So, and these findings can help us to make care better suited for Marfan patients. So maybe we should incorporate more, how do you say that? Interventions for tiredness or for relationship issues. This is an example of the tailor-suited Marfan patient profile card, and you see that it addresses different, mainly different physiological areas. This is joint problems, pain, fatigue, back problems, heart and vascular issues, eye, lung, and shame. This was together with the patient, Marfan patient organization. It was selected. And
can you say what the first one on the right is?
First one on the right. This one?
Last one. Yeah.
That one? Shame. Shame. It's when people feel embarrassed about having differences. This is compared to this is still the same as was with the other one. We added work. There are some questions about work, and we added relationship and sexuality, because due to the frequent use of beta blockers, sometimes that gave problems which people didn't easily talk about. And so that's and there was a question added of child wish and also fear of what is overdraagbaarheid? Fear of hereditary problems in Marfan. So I think that this instrument should be used by all Marfan clinics. And I think it's very helpful in making care for Marfan patients a lot better and more tailor-suited. And yes. Are there any questions? Yes?
The sleeping problems, how do you capture that in
I'll get a profile card. So once, well, I'll take this one. Once there's a problem, then the patient is invited to come and talk about it. So with tiredness, when it's that large high, we start asking a lot of questions. So we go into tiredness, because tiredness is something you can get it from so many things. So it's very important that every complaint is talked about and listened to very carefully. And then the patient will elaborate about the problem, and then you get more idea.
Last meeting in Belgium, I heard that apnea is one of the things that is now very typical.
Yes.
So, for example,
Yeah.
that can come out of this
Yeah.
discussion.
Yes, we do take note. So we try to if there are patterns which we see with more Marfan patients, we, like for instance with the headache, we and then one patient came back and said, well, I went to the dentist and this happened and my headache. So then that happened to another one, and we thought, okay, there's a pattern here. So we called the dentist and asked, well, how come? Oh, well, I've seen more Marfan patients and this worked for that. And so that's how it works. It gives us more insight.
Have you provided this questionnaire to other Marfan users?
Yes, yes.
So you're sharing it? with
Sorry?
them? You're sharing the other patients and the other
Yes.
are also
Yes.
filling in?
Yes, we've just I still have to send out the letter after that. But we've made it now completely available for all centra in the Netherlands. And if we can get a translated version, it can be used in the whole of Europe. Yes. And it's because of the software thing, it needs to go through, but we got an external organization to do that. So you can just send a mail and then apply for it. Yeah.
2 questions. Do you have like a digital version? What I mean by that is, can the patient answer those questions at home?
Yes. Yes.
Okay.
It is in a safe environment, so the data cannot be how do you say that, hacked into, but they get a link at home in their mail, and then they can fill it in, and then we get it back attached to their patient file.
Okay.
Yeah.
And the second question is, who delivers the results, and under which form do you deliver the results to the patient?
We analyze it. If there's no problem, then they get now they get a letter, but we want to have the results back before they come to their visit, and then they will get the results at the same time as they have their visit. And if we see that there's a problem, we want to arrange it in that way that if they come for the visit, then they have a multidisciplinary visit. So if we see that there's a problem in the area of work, then they get the opportunity to speak somebody about that, or otherwise they speak the nurse practitioner, which is me.
Okay. And my last question is, when they come back for the second time, because you said that there was a small percentage that came for the second time, was it to do the same test again? Or not?
No, we offer the questionnaire for like once a year, maximum, and then every year. So a patient gets it sent home every year, so you can see the differences in what happens, and you can use it as a monitor.
Okay. And do you modify the questionnaire the second time based on things that they may have done or improved in the meantime?
Yes, but it was done by because it's evidence-based, so it's built up, and there's a lot of research done. So they did it in a how do you say that? A well-organized way with the person who developed this first questionnaire as well.
Thanks.
More questions? Thank you.
Thank you so much, Daphne. I think besides what the NCSI gives you, it's also a self-reflection for the patient, and the patient becomes a partner of his own care. I think that's very important. Thank you so much. A typical Dutch present from the Marfan Europe Network. Thank you.
Thank you.